Great. Thank you all again for joining us. We are excited to have this conversation today. We are here to discuss research recently released by the Kansas Health Institute, supported by the Health Fund, that focuses on how leveraging the Certified Community Behavioral Health Center model, CCBHC, could help address infant and early childhood mental health. CCBHCs are a new payment model that leverages enhanced Medicaid payments. And as you know, Medicaid in Kansas, known as CanCare, plays an integral role in the health of our most vulnerable residents, serving more than 415,000 Kansans, the majority of whom are children. The program also serves pregnant women, parents, people with disabilities, and the elderly. If we want to improve the health of Kansans, we need to have a strong Medicaid program and to leverage tools like CCBHCs to ensure that we're supporting healthy development in the early years of life. The years birth to age 5 are critical for children's development, with rapid brain growth occurring. This critical window is marked with opportunities to influence children's well-being through early and targeted support. During this time, the brain is particularly responsive to positive experiences, which can be enhanced by nurturing environments, secure attachments, and supportive community networks. In Kansas, there's been a lot of progress in this space and recognizing the importance of infant and early childhood mental health, which is why we're excited that there's opportunities through the Certified Community Behavioral Health Center to strengthen and enhance a comprehensive approach during the earliest years of life to improve health. Today's webinar will feature a presentation from Valentina Blanchard and Cynthia Snyder, who developed the brief from KHI. It will be about 15 to 20 minutes. If you have questions and answers, please put them in the chat. Then we'll have a great panel discussion led by Ann Dwyer with 4 great participants. The presenters will be Ann Dwyer, who's an associate research professor of practice at Georgetown University's Center for Children and Families in the McCourt School of Public Policy, followed by Andy Brown, the Deputy Secretary for Programs at the Kansas Department of Aging and Disability Services. Tim DeWeese will then present. He's the director of Johnson County Mental Health Centers, who has a center that really leads in providing services in mental health. And then Whitney Gruby, an assistant professor at the KU School of Social Work. Before turning things over to Valentina and Cynthia, here are a few housekeeping items. Given the number of folks on the call, the lines are muted. However, we hope you use the chat function throughout the webinar. We will hold a full question and answer until after the panel. But if you have some questions on the presentation, put them in the chat and we may take them before the panel discussion. We will be monitoring the chat throughout, so please put any questions that you have in the chat. And also please, to get things started, introduce yourself in the chat and ask questions as we go along. We will also use the raise hand function later on. So again, thank you for joining us, and we look forward to the discussion and ongoing partners with all of the panelists and all of you to strengthen infant and early childhood mental health in Kansas. Valentina and Cynthia, I'll turn things over to you.
Great, thanks, David. Let me just share my screen. Okay, so hello everyone. Thank you so much for being here today. We're really excited to share this brief on how the CCBHC model can be leveraged for infant and early childhood mental health. I'm Valentina Blanchard. I'm an analyst at the Kansas Health Institute. My work covers quite a few areas, but a big part of what I focus on is legislative monitoring, behavioral health, and access to care, and some facilitation projects. I'm joined today by my colleague, Cynthia Snyder, who is a key author of this brief that we'll be talking about today. And Cynthia is also in the chat to help answer any questions that may come up. I want to acknowledge the rest of our team as well. Carrie Bruffett for her QA and our communications team, Stuart and Kathy for helping with the editing and the creating of the brief. This research was made possible by the Health Fund, so I want to thank them for their support and for hosting this research series. I also want to acknowledge Donna Cohen-Ross, who served as a peer reviewer, and all the organizations listed here that we spoke to kick off this research. Before we dive in, a quick overview of KHI for those who aren't familiar with us. We're a nonprofit, nonpartisan education organization based right across the street from the Kansas state capitol in Topeka. While we're core funded by the Kansas Health Foundation, we also collaborate with state and national partners on projects that impact Kansas communities. Our goal is to always facilitate meaningful conversations about important health topics. Earlier this month, we released a brief highlighting the importance of integrating infant and early childhood mental health, IECMH is what I'll be calling it throughout the presentation, services into the CCBHC model. And this presentation will outline some of the key strategies. And so to give us some background, when we talk about IECMH, we're referring to a child's ability to form secure relationships with caregivers, regulate their emotions, and explore the world around them. These early milestones are crucial for a child's lifelong learning and emotional well-being. And as David said, the first 5 years, which is often called the critical window, is a time of rapid brain development, which makes it the perfect time to intervene with services that can have a lasting impact on health. This is where the CCBHCs are really suited to provide these services. They're able to provide structured, accessible behavioral health services that can address those early developmental needs that support both the child and the family. So the CCBHC model is a holistic approach to healthcare that integrates mental health and substance use services with other community health services. It was developed by SAMHSA and CMS and emphasizes comprehensive person-centered care. They provide a wide range of services, these 9 services that are listed in this graphic that include crisis care, outpatient treatment, targeted case management. Of the services here, CCBHCs have to directly provide the 4 that are in the middle. This model allows for seamless access to multidisciplinary services, which is essential for meeting the complex needs of young children and families. So the prospective payment system, or PPS, is a key aspect of how Medicaid reimburses CCBHCs. The PPS model provides fixed payments for services based on predetermined rates rather than the number of services that are delivered. PPS rates are set by state Medicaid agencies through the cost reporting process, which gives Medicaid directors the ability to benchmark the expected costs of clinics. Kansas uses a daily PPS model, this PPS 1 that you see in the blue, meaning that clinics receive 1 payment per patient per day that they receive a qualifying service, no matter how many services are provided within that day. CMS has recently updated their guidelines to include additional payments and flexibilities for CCBHCs. So that's the 3 and the 4 that you see here. So most notably, new PPS rate options for things like special crisis services and updated guidance on developing quality bonus payments for CCBHCs that meet quality measure thresholds. So in Kansas, there's been some significant strides in implementing the BOT model through Senate Substitute for House Bill 2208, which was passed in 2021. Kansas now has 26 community mental health centers that are certified or provisionally certified as CCBHCs. And these centers are uniquely positioned to provide services to children and families because, like I said, they can coordinate care across a variety of programs. Those programs might include early intervention services, pediatric care, home visiting programs. This map shows the CMHCs in Kansas and their traditional catchment areas. However, CCBHC certification is not necessarily limited by these geographical boundaries, which allows for more flexible service delivery across the state. It's also important to note that CCBHCs are certified by states and not a federal agency. So while the federal guidelines set a basic floor for what CCBHCs must provide, states have some flexibility to determine specific requirements and they can prioritize certain populations. So this allows states to tailor the CCBHC model to their unique needs. I apologize if you can hear my dog in the background. He is deciding to chat right now. Okay, so Medicaid plays a huge role in supporting behavioral health services in Kansas. It's the largest payer for mental health services in the US. One major change that we've seen in Kansas is the extension of postpartum coverage under Medicaid from 60 days to 12 months. And this affects approximately 7,000 women annually and is a pretty significant development because it allows for more comprehensive care during that critical postpartum period, including screenings for maternal depression. So in some circumstances, mothers or caregivers can also be screened under a child's Medicaid ID during well visits for depression. And as research shows, caregiver mental health has a direct impact on child development. Another important Medicaid benefit is the early and periodic screening, diagnostic, and treatment benefit, or EPSDT. This is a federally mandated benefit that ensures children under 21 with Medicaid or CHIP have access to preventive care, including mental health screenings and treatments, even if the service isn't covered under the state plan. So in Kansas, the EPSDT program is called Can Be Healthy. One challenge is the current requirement for a behavioral health diagnosis to access treatment. So for young children, this can be a barrier, and CMS has recommended that states consider removing this requirement, which would allow for earlier interventions based on observed needs rather than waiting for that formal diagnosis. Another service that CCBHCs could provide or provide referrals out for is dyadic treatment, which involves treating both the child and the caregiver together. This approach focuses on improving the emotional bond and relationship between them, which is critical in addressing early mental health concerns. In Kansas, organizations like Kids TLC and TFI are already using this model, but expanding reimbursement for dyadic therapy may ensure that more families have access to these services. So CMS has provided a lot of guidance on improving IECMH services through Medicaid and CHIP that provides an opportunity for CCBHCs. Some of these include states removing the need for behavioral health diagnosis to access EPSDT services. They also suggest increasing access to behavioral health screenings as part of routine well child exams, which would help normalize mental health care from the start and potentially help identify issues earlier. Another recommendation from CMS is the development of robust referral networks. This would make sure that children and families are connected to the right services both quickly and effectively. CMS also encourages states to recognize a broader range of providers who can offer support, including non-traditional providers like early childhood educators, home visitors, and others who may have already have established relationships with families. And then more utilization of telehealth is another recommendation that would allow families, especially in rural or underserved areas, to access services without the barrier of distance or social determinants of health like transportation. Let's dive into some of these a little bit further. One of the most important strategies CCBHCs can use to improve IECMH services is strengthening their referral networks. They're in a unique position to act as a central hub to link families to a wide range of services that they might need. It's also important to note, though, that each community or local network might look different, so the partners involved in the referral networks might vary. By tailoring the networks to meet the specific needs of their communities, CCBHCs can ensure that families are connected to the resources that will be most beneficial to them. Listed here are just some referral partners to think through. There are quite a few. Expanding workforce capacity is another strategy to improve IECMH services, particularly given the shortage of mental health professionals trained in early childhood development. This is something that we heard from multiple people as we were starting our research. In Kansas, 96 out of 105 counties are designated as mental health professional shortage areas, which can make access to care difficult for families. So to address this, Kansas could expand training opportunities, not only for mental health clinicians, but also for other care professionals like early childhood educators, home visitors, community health workers. These professionals already have a strong and trusted relationship with families and can be trained to recognize early signs of mental health issues in young children. So by providing specialized training in the IECMH frameworks, assessment tools, intervention strategies, there can be a more integrated and collaborative system of care. This also could include rethinking training and licensure requirements to address workforce, i.e. CMH consultation services. Sorry about that. Another strategy is the use of age-appropriate diagnostic tools. So for young children, traditional diagnostic frameworks like the DSM-5 can often miss the mark because they're designed for older children and adults, so like 11 and above, essentially. The DC 0 to 5 was specifically designed for the 0 to 5 age range, and it provides developmentally appropriate diagnostic criteria that are better suited for young children's needs. It's a tool that allows providers to accurately assess mental health conditions in children. Crosswalking the DC 0 to 5 diagnoses with current diagnostic codes that are reimbursable might be the typical current practice, but could still miss some of the nuances seen for younger children. Some states, like Washington and Nevada, have already integrated the DC 0 to 5 into their healthcare systems in different ways, through legislation or through the electronic health record system, but this could improve the accuracy of the mental health assessments. Kansas doesn't currently recognize DC 0 to 5 diagnoses for reimbursement, although I believe it is being explored. So to kind of wrap things up, the CCBHC model can really offer a promising opportunity to enhance IECMH services in Kansas. By integrating services across multiple disciplines and expanding access to care, children and families can get the support they need at the right time. So things like adjusting Medicaid policies and strengthening our referral networks can help make services more accessible, especially in rural and underserved areas. And I think we'll see this with Kansas's recent selection as a Medicaid demonstration state, that there are opportunities to expand and innovate. Additionally, focusing on workforce training and utilizing tools like the DC 0 to 5 can help address those unique developmental needs. So as Kansas continues to explore these strategies, ongoing collaboration across different sectors with mental health providers, healthcare practitioners and pediatricians, early childhood educators, community organizations, just to name a few, will be crucial in building a responsive, effective system of care for the youngest members of our community. I think I will pass it back to David.
Excellent. Thanks, Valentina. Great job. Does anyone have any specific questions for Valentina before we turn things over to the panelists for their reactions? If you have any questions, please put them in the chat. There'll be plenty of times for questions and answers later. And I think Valentina's last slide really set up the reaction panel well, because all of our panelists will be able to speak directly to both future opportunities and then the larger vision for CCBHCs, both nationally, in the state, and then on the ground. So we're excited to have a great panel. Ann Dwyer from Georgetown Center for Children and Families and the McCourt School of Public Policy will kick things off, followed by Deputy Secretary Brown, Tim DeWeese, and Dr. Gruby. Ann, I'll turn things over to you.
Great, thanks so much, David. And thank you for the introduction, and Valentina for the great overview of the report and the CCBHC model. So as David mentioned, I'm Ann Dwyer, an associate research professor at Georgetown University's McCourt School of Public Policy Center for Children and Families. CCF is a nonpartisan policy and research center with a mission to support access to high quality, comprehensive and affordable health coverage for America's children and families, really with a particular focus on policy development and implementation efforts related to Medicaid and the Children's Health Insurance Program, also known as CHIP. So alongside a few of my colleagues, I work on issues related to children's behavioral health, including mental health at CCF, and have been tracking efforts around implementation of Medicaid CCBHC demonstration, in particular, kind of this national review. So I have just a few. I think the report is great. It's so wonderful to see a state-focused report and a report focused on infant early childhood mental health. And I have just a few additional policy points I wanted to lift up a little further. But before I get into some of the policy weeds around CCBHCs, I wanted to take a step back and mention the important role Medicaid plays for children and families with mental health and substance use disorder needs. As many of you may know, Medicaid is the single largest payer of behavioral health services in the country. In addition, in Kansas, Medicaid alongside CHIP, which is an important program, but much smaller than Medicaid, covers about a third of children. So when you talk about mental health care and children and families, Medicaid is really a key component. And also why having a strong and supported Medicaid program is integral to the success of the Medicaid CCBHC program. So just wanted to highlight that backdrop. As I mentioned, I wanted to lift up really two key areas where CCBHCs can be leveraged to support children and families. So the first is related to what is known as Medicaid's early and periodic screening, diagnostic, treatment, or EPSET benefit or requirement. So and Valentina touched on this a little bit, and I just wanted to dig a little bit further into this because it's really important. It's a really important protection for children in Medicaid, and also CMS has done some more work around the EPSET benefit, and that has come in reaction to the Bipartisan Safer Communities Act, which was kind of the gun safety bill, mental health bill that passed in the summer of 2022, which included some very specific provisions, congressional mandates to the federal government to really drill down more into EPSET and Medicaid, how it's working, and to work with states to make it work better. So there's a number of mandates in that bill. I can throw a link to an overview of that. Those requirements in the chat at the end of my remarks, but it's really an area where I think that is getting renewed focus. So just as a reminder, the EPSET requirement means states are required to provide comprehensive services and furnish all coverable, appropriate, and medically necessary services needed to correct and or ameliorate health conditions, including behavioral health conditions, if the service could be covered under the state plan. So that means any service listed in 1905A of the Medicaid statute, regardless of whether it's in the state's plan, if it's listed in the statute, it's medically necessary and is needed to correct or ameliorate a health condition, it needs to be covered when it comes to children in Medicaid with EPSET protections. And CMS recently put out some guidance at the end of September where it's new guidance focused on Medicaid's EPSET requirement, where they really highlighted that this benefit creates a higher standard for children than adults in Medicaid in terms of coverage. And it includes a number of policies and state strategies for improving care for children with behavioral health needs. So we have a blog series. Again, I'll put some links to these in the chat at the end of my remarks. So we have a blog series on the CCF website breaking down the 57-page guidance to states, including on the behavioral health provisions in that guidance. There's a lot in there. As I mentioned, I think it's about 57 pages. It's more than we have time to completely unpack today, but I did want to highlight a few policy points that I think are relevant for any discussion around CCBHCs and the role they can play to support infant and early childhood mental health. So for one, as Valentina touched on, CMS reiterates in this guidance that states should avoid requiring an EPSET eligible child to have a specific behavioral health diagnosis for the provision of services. And they note that this is maybe particularly important and salient when addressing the developmental and behavioral health needs of children under the age of 5. CMS also notes in the guidance that a service array of behavioral health care that is consistent with EPSET requirements includes, but is not limited to, screening and assessment, services to build skills for mental health and or to address early signs or symptoms, community-based services at varying levels of intensity, services to address urgent and crisis needs, and inpatient care, but only when medically necessary. The guidance also highlights CCBHCs when talking about best practices for states in creating a seamless and comprehensive behavioral health system for children in order to comply with EPSET. So ultimately, states really have an opportunity here to support and leverage CCBHCs to meet their EPSET obligations under Medicaid, especially when it comes to infant and early childhood mental health. As again, the guidance makes clear that the diagnosis is not required under federal law for the provision of EPSET services. And as I quote from the guidance, as with a physical health condition, states must ensure that behavioral health symptoms that are identified through screening are addressed in a timely way, as waiting for an illness to develop rather than addressing symptoms when they arise is not consistent with Section 1905R5 of the Act. That's the Social Security Act, the Medicaid statute they're referring to there. So that's the first area. I know it can get a bit weedy, but again, we have some great resources on the CCF website that I will put in the chat, or I think maybe a few others might have already done. So that's the first area I wanted to lift up for you on today's call. The next quickly is around opportunities to support children and families in ensuring they are enrolled in coverage. So again, as many of you may have likely been tracking, Kansas, along with states across the country, recently completed a major Medicaid coverage renewal process as part of the unwinding of the COVID public health emergency and the Medicaid continuous coverage protection. Sadly, the nation saw a net decline of child Medicaid enrollment of over 5.5 million children, including a net decline in Medicaid enrollment of over 50,000 children in Kansas as of April 2024. Overall, nearly 95,000 individuals of all ages lost their Medicaid coverage in Kansas during the unwinding due to procedural reasons. So this is due to things like paperwork issues, mailing problems, but not because the individuals were proven to be ineligible for coverage. As a result, it's likely that many of these individuals, many of which are likely children, especially in Kansas as a non-expansion state, are still eligible but not enrolled in coverage. However, under SAMHSA's CCBHC certification criteria, which I can also throw a note in the chat if that's not already in there, or a link to that. One of the requirements is that CCBHCs assist people receiving services and families to access benefits, including Medicaid. And just as a reminder here, we're talking about children and families that are eligible. So they are eligible for Medicaid, but they may not be enrolled in coverage. So this is especially important for young children and new mothers when we know how critical those first few years are. So in addition to ensuring individuals are insured, it's not only beneficial for the children and families, but also for the CCBHCs so that they can receive sufficient reimbursement for the important services they provide so that they can receive their PPS. So it's kind of a win-win for everyone involved. So those were the two main things I wanted to highlight. I'm happy to chat more during the discussion period. So I want to thank you for my time, and then I will make sure to pass it over to Andy, who I think is our next panelist.
Yeah, hello everyone. I'm happy to be here today, and for anybody that doesn't know me, I'm the Deputy Secretary for Programs at KDADS. I wanted to kind of share, like, I think Ann and Valentina did a great job already talking about a number of things, but I'm going to try to cover a couple of different topics, and then hopefully maybe share some things that are of interest. And I wanted to say that first off, the potential for CCBHCs to strengthen infant and early childhood mental health services is pretty significant. And these are kind of touch points that you've maybe already heard, but the comprehensive service model, so CCBHCs are structured to provide that full range of mental health services, which can include early childhood focused care. It supports comprehensive integrated approaches that are particularly effective in addressing the needs of young children and their families. There's early identification and intervention. So CCBHCs can offer screening and diagnostic services that identify developmental and behavioral concerns early, enabling timely intervention and reducing the impact of childhood trauma and other mental health challenges. For funding and resource allocation, CCBHC status provides access to dedicated funding and resources that can expand the reach and quality of early childhood services, especially in underserved areas. CCBHCs can attract and retain professionals, so we're enhancing our workforce development. And we can do that through competitive salaries, resources for ongoing training in specialized areas, like infant mental health and trauma-informed care. And I think, one point I'd like to make about sort of that funding and resource allocation. So in state fiscal year 21, we had an annual amount of about $115 million that our community mental health centers were billing to Medicaid. And those went, back to providing services in the community. Our model now in state fiscal year 24, under the CCBHC model across the state, we're now spending in the neighborhood of about $320 million a year annually. So that's a $200 million a year increase in the amount of funding that our state is using through our Medicaid program to support behavioral health care in the community. Second, CCBHC care coordination and our MCO contracts for CanCare 3.0. First off, we want to talk a little bit about the integration into CanCare 3.0. So it was already mentioned that we're now a demonstration state with CMS, and we're also launching new contracts with 3 MCOs to help manage care. There's a care coordination role within the CCBHCs that offers an additional opportunity to create seamless service delivery across providers and sectors, particularly important in managed care. So embedding these CCBHC requirements into our MCO contracts helps ensure continuity and clear responsibility for coordinating services for children and families. Additionally, there's the the care continuum and coordination requirements. So our contracts mandate that MCOs work closely with the CCBHCs to support coordination among primary care, mental health, social services, specialty providers, in order to ensure there's a continuum of care for behavioral health and physical health needs that their patients are receiving. And then there's also the financial and structural incentives. So including the CCBHCs and our MCO contracts helps align our funding incentives and the P4Ps that our MCOs benefit from. So about half of the total P4Ps that are in the new contracts are related directly to behavioral health. And that allows the CCBHCs to serve almost like medical homes or central points of contacts for families in their communities, which will help improve outcomes for young children and their caregivers. And to that point, I'd like to just let you guys know that we've included in the contract language that requires a CCBHC position at each of the 3 MCOs to help coordinate and provide some oversight of the CCBHC programs, as well as make sure that the connections between the CCBHC community care coordination efforts and the MCO care coordination efforts are occurring. And then third, I want to talk a little bit about the connections to family therapy and parent peer support and some of the early childhood efforts that are ongoing within the state. So for family therapy integration, the CCBHCs are well positioned to provide family-centered care, including family therapy. And we also now have added a code to our Medicaid services that's family therapy without the patient present, which means that if you have a dyad of a single mom and an infant that are Medicaid eligible, you can provide family therapy to that mother while that infant isn't present, right? So that's a way that we're able to provide those services to the family, even if the parents don't have a diagnosis. Additionally, looking at parent peer support, this is a new service here in Kansas. We've established parent peer support. This is the idea of embedding peer support services that allow parents and caregivers to receive guidance and emotional support from other parents with lived experience, which can improve engagement and treatment and enhance family resilience. And then, we've had some ongoing focus over the Kelly administration around the 0 to 3 population, both at KDHE and KDADS and DCF, to really look at how we can support early intervention efforts. CCBHCs can help fill critical gaps in services for infants and toddlers, including developmental screening, parent-child therapy, support for secure attachment, which are all essential components for early mental health and long-term wellness. And then lastly, on the topic of EPSDT guidance on CCBHCs, those mandates under Medicaid are for comprehensive and preventative healthcare services for individuals that are under 21. So this aligns well with our CCBHC's focus on providing all-encompassing mental health and related services. It aligns the CCBH services with the requirements. So CCBHCs can ensure compliance with EPSDT by offering mental health screenings, diagnostic services, and treatment for children. And they can also help connect families to additional supports, like Anne was talking about, in the community when those are identified, and promote early intervention. And then the last one really is around enhancing the outreach and engagement. So CCBHCs are equipped to facilitate outreach and increase engagement with families who may be eligible for those services, improving access to needed care, especially for those underserved populations again. So hopefully that'll help kind of enhance the understanding of how CCBHCs can play a role in this. And I'll pass to Tim.
Thanks, Andy. I think so far, so much of the information that we've provided really outlines what CCBHCs are, what they do, and how we are moving within the state. So what I'd like to do is provide a perspective from the provider's perspective. I like to say, and I've said several times over the past couple of years, that it is a good time to be a mental health center director, CCBHC director in Kansas, because there are all kinds of opportunities. The issues are about access to care, and being able to connect people with that care. And so we've talked a lot about that before. Historically, the community mental health system was built on a responsive system. So you had situations where people responded to individuals having experiencing symptoms that were in crisis, whatever it might be. And so what we see with CCBHC, and in particular, when we look at this policy brief, is that we begin to move downstream. So we begin to talk about things like prevention efforts and things like that. But now what we've gotten to is leveraging the CCBHC model with addressing infant and early childhood mental health. And what's important for us to remember is that the neuroscience is clear. Understanding the impact of trauma on the brain and the body is critical for us to ensure that we can eliminate or prevent some of the long-term impacts, both physical impacts as well as mental health and emotional health impacts that root cause of trauma has. And so when we started off this presentation, we talked about emotion regulation. It was mentioned, and the importance of stress. Again, the neuroscience is clear. If we can ensure that parents, caregivers have good developed relationships with these youngsters at an early age, that we learn then to help them regulate their emotions, reduce the stress, and what we should see is a reduction in the long-term healthcare impacts on that individual. And so from a mental health center standpoint, from a director standpoint, from a clinician standpoint, it's exciting to be able to take a look at how not only can the CCBHC model help us respond and provide access to care, immediate access to care when people need it, but we begin to look at how can we proactively prevent major mental illnesses, major health, chronic health conditions from ever beginning in the first place, as we help people, one, regulate their emotional state and decrease the stress that exists within families. Within Johnson County Mental Health Center, we have looked at all kinds of different ways, and as we continue to develop the CCBHC model here in our community, we'll continue to look at our postpartum coverage that we work with our local health department on. We will continue to look at the didactic treatments, in particular with child and parent psychotherapy, parent peer support that the Deputy Secretary mentioned. We had also started prior to the pandemic. We wanted to look at providing some attachment biobehavioral catch-up therapy, ABC, which has proven to be very effective. And we worked with the University of Delaware to get a couple of staff here trained and to fidelity in that model. And so we haven't had the ability to actually be able to be reimbursed for those types of services. So with the implementation of the CCBHC, we have this not only opportunity to be reimbursed the cost of the service, but actually be able to move in front of some of these major mental illnesses from ever getting started within the role of a family or an individual. So again, excited, was really excited to have the opportunity to read the brief, and excited about being able to look at how we can utilize these services, these partnerships across our community to provide better full services across the entire lifespan of an individual. And with that, I will pass it off to Dr. Whitney.
Thank you. Thanks, Tim.
Yeah.
Hi, everyone. Good afternoon. My name is Whitney Gruby, and I am an assistant professor at the KU School of Social Welfare. And I just wanted to say thank you to Katie and David and the entire United Methodist Health Ministry Fund team for inviting me. I have worked with them for a long time now. Actually, ABC has gotten mentioned several times on this call. I have worked since 2017 on evaluating the ABC intervention in Kansas. So it is great to hear how it's being implemented in other sites. My practice background and area of scholarship is really serious emotional disturbances in children, and then the community mental health supports available to them. And I have a particular interest in how that manifests in young children. And I appreciate all of the comments so far. There was a couple of things that I think I wanted to add as it relates to really what CCBHCs can do. And the first thing that came to my mind after reading the brief was the role of data and what we can do with data and leveraging CCBHCs to collect data. I'm an evaluator. I think it's a great opportunity to look at how we can track outcome data over time and really see the long-term effects that these models are having on children. If we think about like school readiness for early childhood, that's some of the stuff that Katie and I have worked on recently for ABC, is looking how that impacts school readiness. And so I immediately thought of that. I think it's essential that we have data that can show that early interventions really are leading to sustained positive outcomes. I also just wanted to say I really appreciated the Deputy Secretary's comments about family therapy. That's one of the things that stuck out to me too, as this opportunity for dyadic treatment. And that is what ABC is. We know that dyadic treatment can really break the intergenerational cycle of dysfunction, of trauma. And so building those kinds of services up are super important, and addressing parent stress is also just super essential to seeing any sort of improvement. That's some of the work that we've also done in ABC. Is we recently examined how that model influences parent stress, and we found that there are improvements in that. And so again, thinking about how we can continue to collect data on that so we can show long-term effects. The last thing that I was super excited about was the opportunity to address the workforce issues. That's a huge problem. It is not local to Kansas, I will say. That is a national problem that every state is experiencing, this crisis in behavioral workforce shortages. And I think CCBHCs can offer a real opportunity to address some of that through competitive pay. I think the Deputy Secretary mentioned some of that as well. And coming from a university perspective, I'm thinking in my head, how can we better address the early childhood issue in terms of maybe partnering with CAIM to offer like a certificate in early childhood for our graduates, or doing some things at the undergrad level so people don't have to go on to get a master's to provide some of these services, which is, again, ABC is a great program for that because there's no specialty degree requirement of any kind. So those were just my thoughts. I really appreciate the opportunity. Like I said, I really appreciate all of the comments before me too. So I will turn it back over to, I think, David.
Yes, thank you, Whitney. And thanks to all of the presenters. I think it was really a lot of ground covered. Do folks have any questions for the presenters? I know there was a couple questions in the chat in terms of just interest in referral networks and holistic care, which I think I think some of the goals here is how can we ensure that we have early interventions, prevention, and really coordinated whole person care, and how can the systems work better together? So I don't know if any of the presenters have comments on that. While folks think about that, I do think one of the themes that came up is just really how important the Medicaid program is to both ensuring children and families have access to services in Kansas, as well as how important Medicaid is to ensuring that we have a strong behavioral health system. And hopefully we won't be having discussions about this, but there's the potential for potential threats to the Medicaid program. One thing that I was sort of struck by Ann's comments, and I don't know if anyone else wants to add more, or Ann may want to, was just the potential for CCBHCs to play a role in enrolling families into coverage, and being able to sort of pay for those positions through the new model. So I don't know if anyone has any thoughts on the role that CCBHCs can play in helping connect people to coverage.
Yeah, so David, we've had historically a perspective of using programs like SOAR, SOAR, to help connect people to disability benefits and eligibility through Social Security, those kinds of things. And so this is really, under the CCBHC, sort of an opportunity to expand that role to include other eligibility programs, including Medicaid. And so essentially, like when we look at care coordination, the care coordination criteria within the federal criteria for CCBHCs specifically calls out what Ann referred to there, which is that there's an expectation that the CCBHCs will, as a part of that care coordination, connect people to benefits by helping them with applications, by getting them to appointments, by helping them collect paperwork that's required for the submission, those kinds of things. And while we've done a lot with the SOAR program at the federal level to try to make that work for our adult populations, this is an opportunity for us to sort of extend that into that opportunity. So when we're doing community outreach events, when we're doing partnerships with collaborating organizations that might be doing physical health screenings or things like that, if we can connect those families to the CCBHC to get assistance with actually applying for those services, they can do that. And then that all kind of gets encapsulated within their PPS.
Yeah, which I think is a really important thing to lift up. So I appreciate that. Thank you, Andy.
Yeah.
Any other questions? I have a few more, but I want to make sure that there's space for others to chime in. One of the other things that was lifted up as part of the discussion, both in the brief and with a number of the reactors, was recent guidance from around EPSDT in terms of not requiring a diagnosis for accessing services. And I think that the state was in some ways moving in that direction, through DC 0 through 5, and they're aligned. I don't know if Anna, it makes more sense to unpack a little bit more about sort of the importance of kids being able to access behavioral health services without the diagnosis. Or Andy, I know you and your team have been working hard to make sure that both through the managed care contracting process and CCBHCs, that there is access to care coordination and some family therapy services without the diagnosis, recognizing either because it tags the kids with, an SED or co-occurring diagnosis in order to get services or not. But I think you guys were moving in that direction and the guidance clearly went there. So I think it would be great if we could unpack this a little bit more. And if there's things that we need to do as partner organizations, stakeholder groups to help support the state moving in that direction.
Yeah, and
I'm happy to.
Yeah, go
Go
ahead,
ahead, Andy.
No, you go ahead.
I would just say I'm happy to jump in at the kind of 10,000-foot level, federal level. I think that in some areas there has historically been a misunderstanding that the federal statute did require a diagnosis, that like you need an ICD-10 code, that you need a specific diagnosis in order to bill. Well, that has sometimes been the way that it's practiced. There's actually nothing in the federal statute that requires a diagnosis. And so I think that's why CMS has really been clear. They came out with guidance in 2022, informational bulletin on leveraging Medicaid and CHIP to support behavioral health care for children. I'll throw a link to that in the chat if folks are interested. And there they said a diagnosis is not required under federal law. It does have to be medically necessary. So there's still checks and balances, still, a medically necessary service that is to correct or ameliorate a health condition. So we are, we still need to document that, but it doesn't necessarily require a diagnosis. And we know, especially for young kids, that a service can be medically necessary without a diagnosis necessarily being attached to it at that point. So we have seen some states move kind of more specific, clear actions in this space. So California is one state, Colorado, they passed legislation saying services for children must be provided without a diagnosis. I think some states are maybe moving more towards this in practice and doing things like Z codes. So I defer to Andy and others how Kansas might be thinking about it, but this definitely, I think, is an idea that is gaining more momentum of it's not required. We have to demonstrate medical necessity, but how do we actually modify the systems to make it work when everything in the system is always requiring the ICD-10 code to go with it? And that's just kind of blocking things up.
Yeah, and I would say, David, that we've got some people in this room right now that are probably better experts about this than I am, right? With Linda and Kelsey here. But what I would say is that we recognize that that guidance just came down in September, right? So we haven't really had a chance to act on it. But we do intend to have a group that's working at KDHE and KDADS to sort of review the EPSDT state plan information. And there are other pieces of that guidance that are outside of the behavioral health even that I think we're going to have opportunities here in Kansas to expand upon and utilize. And then there's also a little bit of a piece of that connects back to guidance that we got recently around school-based services and how we can expand school-based services as well. And I think CCBHCs ultimately can play a role in both of those components, where we're looking at trying to make sure that children have access to care and that we're doing those screenings and referrals for treatment in a way that's both early and effective.
Thank you for that. And I think that's helpful. And I think I know we'd be happy to help. And if there's other stakeholders here, like CAIM and others, I'm sure there's folks that would be happy to help the state as you guys work through that. And you guys have been so forward thinking on a lot of these issues, so we appreciate that. Any other questions that folks have? I'll ask one more because it came up, and I think Valentina and Cynthia and the team at KHI did a good job highlighting the opportunities around workforce. And I think to Andy's point earlier, like the state has been forward thinking on parent peer support and others. Is there an ABC came up as an opportunity? I know that the ABC is being deployed at Johnson County Mental Health. Is there other creative ways we can leverage this payment to both recognize and sort of finance services through expanding care teams, following the parent peer support model or the CHW? How can we look at expanding home visiting models like ABC that are evidence-based that may not require a master's degrees? And I don't know if anyone has any ideas on that front.
Well, on the financial side of that, David, I'll say that the CCBHC model really does allow for multidisciplinary teams and for services that are provided outside the four walls of a center. So really, to kind of to Tim's point earlier, CCBHC directors have the opportunity to look at what types of evidence-based programs they want to include in their service based on their community needs assessment. And as long as we're able to tie those evidence-based practices to the training and fidelity that Tim mentioned, and to the community needs assessment, as long as those contacts that are happening have what we call an encounter code associated with them, then they would be able to draw down that PPS encounter rate.
So David, from my perspective, when we talk about workforce development, I think all of these opportunities are that we've talked about thus far have been good, and being able to have the PPS rate and have it be a cost-based reimbursement has allowed us to be able to pay all levels of staff a little bit more, so that, when you're in competition with the local McDonald's for somebody that has a high school diploma, the work that we're doing is hard. It's tough. And so being able to increase those wages a little bit, because we actually finally got a reimbursement rate that helps cover the cost, is huge. From my standpoint, beyond those things, to me, it's really also about developing the workforce, and in my mind, we need to move upstream on that as well. So we do a lot of work with the University of Kansas, and we have a ton of students that come here that are working on their bachelor's degrees, working on their master's degrees. But one of the things that we've started doing here more recently is really starting to work with high schools, so that we can begin to introduce this career path of community mental health centers, of CCBHCs, to young high school students. Because if you go and talk with a high school student today, they're going to say, well, don't you have to have your doctorate, or don't you have to have a master's degree to work at the mental health center? And the bottom line is no. There's a career path the minute you graduate from high school at a community mental health center or a CCBHC. So I think we have to make young people aware of and from my standpoint, it's about working in public service. It's about working in those kinds of fields. And I think this new generation, this generation that's in middle school and high school right now, are quite frankly, they're ripe for the picking. They have a ton of the soft skills that are needed for our services. And so I think that's where we've actually spent a lot of time here recently, is to try to educate them and then direct them to the right programs when they graduate from high school.
Thank you for that, Tim. We are at time. So if folks have pressing questions, send them after. We'll get them off to panelists. I want to thank all of the presenters, Valentina, Cynthia, for the great work on the research brief. Thank Anne, Tim, Whitney, and Andy for their great reactions and for the discussion. And then thank the team at the Health Fund, Nancy, Katie, Jeff, for helping pull together this work. It was really great to partner with KHI on this work. And I think Tim's last comment on workforce dovetails to an earlier brief from this year that the team at KHI did on how to expand the workforce. And I think that these are important conversations that I expect to continue. So another plug: next Tuesday, the third research webinar, will be releasing the next phase of results from the ABC evaluation. So it's a good follow-on to the high-level discussion today. So we hope you'll join us. Thank you all again, and have a lovely day.